The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. One of the great things about this whole thing for me is somebody asked me a couple of weeks ago how I stay caught up with stuff in medicine, and being essentially kind of path of least resistance sort of guy, what I do is when I'm interested in something, I get to ask nice people hard questions and they fill me in. This month, we're talking about something that I think none of us talks about enough, and that's the relationship between congenital heart disease and neurodevelopment. And so we have a few people over the course of the month who are going to walk us through this, because I think there's some fascinating stuff to talk about here. We're going to have different guests for each of the first 3 weeks. Our guests this week are Kristi Glotzbach and Laura Wood. Welcome to the podcast, Kristi and Laura.
Thank you. Thanks for having us.
Let's talk a little bit about both of you, because both of you, I think, bring a very unique set of qualifications to the table here. Now, Kristi, you're either a very ambitious scholar or unfocused. I'm guessing it's the former. You've had a lot of training in your life.
I do. Finally, I stopped training actually about 15 years ago, which has been great. And I've been a practicing cardiac intensivist since then. Lots of different pathways through cardiology, through critical care to do what I do. But I've been grateful to take care of patients with congenital heart disease in the cardiac ICU for the last 12 or so years after my fellowship training. And thankfully, it's always been important to me to go back to my general pediatric roots. And so I've kind of crafted my ICU career around neurodevelopment and its correlation with congenital heart disease.
And let's be honest, your training has taken you from sea to shining sea. So, so you did your undergraduate work at St. Mary's, then you went to medical school in Tulane. So the one place we're not going to get you is all the way to the north. That'll be next week. And then you did your, none of this comes as a surprise to you, I'm sure. You did your residency in North Carolina. Then you went back to the West Coast to Stanford for your cardiology fellowship, and then back to Duke for your critical care fellowship. Now, was that your plan all along, or did you just find that you needed more information to be able to do what you do?
Oh, that is a really important question. I think along the way we find ourselves in medicine, right? I think that we find what is intellectually intriguing and the patient population that we like to take care of the most. And so I never wanted to take care of adults. I always wanted to take care of kids. And I always wanted to take care of the sickest kids. And so I found those kids in cardiology and critical care. And the way that training pathway goes, you can do it various different ways, but I just found my passion and found different places to do it. I think that training in different places provides an immense amount of perspective, that there's no one way to take care of kids with complex medical problems. And I think it has served as an amazing foundation for me to be able to do what I do today. I also am married to someone who's in medicine who also has a similar bouncing training pathway in order to be able to facilitate the maintenance of my personal life. I've also had the opportunity to train at great places because we've worked together to make it work for both our careers and our family.
Well, I like to think selfishly that your entire CV adds up to you being the perfect guest for our podcast.
You're so kind. Thanks for the invite.
And Laura, you likewise have a lot of training. And the thing that I think, again, makes you perfect for our podcast, you did a postdoc at Harvard looking at this very theme, right?
Yeah, I was part of Boston Children's Hospital cardiac neurodevelopmental program before I came here, which set me up nicely to focus on the interaction between cardiology and neurodevelopment, but also to really get a better feel of families in a hospital setting. What are the things that are important to families, and how does it impact their day-to-day?
I think that'll develop over the next couple of weeks, that having an integrated approach to how that all works is absolutely vital.
Absolutely.
All right. Before we start, do either of you have any disclosures?
No disclosures.
Okay.
I don't have any either. Thanks.
Let's dive right in then. So first of all, just to sort of lay the foundation, how common is congenital heart disease in children?
I will say, with my day-to-day work, it feels like everybody has congenital heart disease. I'm surrounded by it for sure. But really, it is actually pretty common. And so the numbers that we throw around to patients and families is that 1 in 100 live births will be affected by congenital heart disease. I think the challenge with that number is it makes it sound really common, but it is such a spectrum of disease and conditions that range from, the simplest defects that may resolve without an intervention to these like more complex congenital heart lesions that require multiple surgeries or catheter-based interventions during infancy and throughout the childhood and lifespan that really kind of defines the spectrum of that disease. And so if you take that 1 in 100 and you really break it down, about a quarter of those patients are the patients that I take care of on a regular basis. Those are kids who are born with congenital heart disease that's complex. And we categorize that as kids who have to have surgery within the first year of life. So really, again, this is the patient population that we come into most contact with in the hospital. These represent actually the patients who are at highest risk for developmental challenges, which is why we're talking about them today. And so interestingly enough, the 1 in 100 has been a mainstay throughout my training and throughout my practice. But the prevalence of children and adults living with congenital heart disease has increased over time. And so I think that's really the crux of this and kind of why we're here today to talk about some of the other consequences of their congenital heart disease.
Well, it's safe to say that while the prevalence may not have changed very much in terms, incidence, but you mentioned kids have a lot of procedures done. It seems like there's been a great improvement in survival in this population.
I will say it has been such a privilege to be able to be part of the evolution of pediatric cardiology and the care for these patients over the last 20 or so years. I think survival is a really hard thing to capture just because it is such a big population across the country and across the world. But I will say, and the most recent data that we have is kind of back 10 years or so ago. But I will say even that data supports the fact that survival has continued to increase. And most significantly in our most complex patients, and we know that the survival obviously varies by lesion, but the patients that we see most of the change in are these kids with critical congenital heart disease. So those kids who have to have an intervention in the first year of life. And I think gratefully, on average, about 75% of those kids who have to have surgery in the early portion of their childhood survive to hospital discharge. And I think if you take all comers with that critical congenital heart disease or complex congenital heart disease, about 60% of those kids are even surviving into the third and fourth decade of life. So in general, the numbers have increased significantly. The numbers are still a little bit more challenging. Survival for the most complex lesions doesn't reach those numbers, but we have seen significant improvement in the survival of patients with the most severe lesions like hypoplastic left heart syndrome or single right ventricle circulation. And those outcomes only just continue to improve.
And the narrative to those families is much different than it was 20 years ago.
Absolutely. We're grateful 20 years ago to have those patients survive to hospital discharge. And the conversations that we're having these days with families is about survival to hospital discharge through the stage palliation. And then even in the periods in which we're taking care of them at their first surgery, we're talking to them about what, 15, 20 years ahead looks like.
That's really quite striking. So, Laura, survival's improved, but what we find is that there are then developmental challenges for members of this population. What can you tell us about that?
Yeah, so we've learned a lot as survival rates have improved and we've improved our monitoring of this group. We've realized that while survival has improved, developmental challenges persist for these families, for these children and families. Neurodevelopmental delays and disabilities are actually one of the most enduring and impactful challenges faced by individuals with CHD and their families. There is a wide range of outcomes. And so when we think about a child with CHD, we have to really think broadly about what areas of development to consider. And when I explain it to a family when they're going through like the fetal diagnosis or learning for the first time that their child has CHD, a lot of times their questions start off very medical and about survival. As they start to kind of come to more terms with what it's going to be like from the medical perspective, they do start asking questions and wondering about, well, what is this going to be like for the child? What is this going to be like for my family? And so what I often describe to parents as I'm exploring this with them is that there's a high rate of low severity needs for this population. And that's something we'll touch on quite a bit as we talk over the next month. Because I think it's important to remember that even things that are considered not as severe for a family can have huge impacts for their day-to-day and for that child's progress in school and their participation with friends and as they develop their motor skills, their language skills. The areas we focus on really depends on the age of the child as well.
Let me ask you a question that may not be entirely fair. Do we know why there's this association? Is it purely related to cardiac function, or are there other associations?
I'm happy to speak to that.
Sure.
I think we are learning so much more, to Laura's point, about now we're talking more about kind of long-term implications. But I think that with collaborative research and the way that we have kind of structured the world of cardiology, we have learned a lot about brain development and the time points and the contributing factors. I think we would be grateful if there was one thing that we could kind of hang our hat on in terms of what we think leads to some of these delays. I think some things that we've understood over time is that we know that these kids with congenital heart disease, when they're born, even if they're born at term, their brain development is about 4 to 6 weeks behind that of a healthy term newborn. We know from research studies that they have lower total brain volume, they have abnormal brain metabolism, and about a quarter to a third of these kids already have white matter injury at the time of birth. So there are some kind of fetal life contributors. And then you put that in context of these baseline abnormalities, which put them at higher risk of later insult. And then you add the initial and the repeat surgeries, the frequent hospitalization, the chronic physiologic perturbations with repaired or unrepaired congenital heart disease along the way. And then other factors like parental mental health, other social determinants of health that then subsequently kind of layer on top that contribute to these developmental challenges that we see in our patient population.
Laura, could you walk us through what some of the main areas are where the delays show up?
Yeah, so there's a wide variability in outcomes for children across the different ages. During infancy and early childhood, the challenges that we tend to see come up are related to things like sleep and feeding, and that ability for a baby to kind of regulate their selves to be able to be open for that engagement with their parents. We also see in infants and babies delays in their motor development. If you think about what a child goes through in those early days, going through surgery and being in a hospital, there's less opportunities for them to actually engage in these motor activities. There's less opportunities for them to be on their belly and do tummy time, the things that we just naturally do with our children at home. A lot of our babies also have lower energy levels coming out of surgery or due to their heart condition, and so they have less energy to practice some of these motor skills. So in that first year of life, the things we really look at are the motor development, the feeding, sleep, and kind of regulation as a baby. As the baby gets a little bit older and we start to look at those areas that affect language and communication, even as an infant, we can start to see differences in the amount of babbling they do and the amount of kind of that joint attention they have with their parent. And so we can see the early signs of language delays. And then as we expect that words are coming along and communication is becoming more sophisticated, we do start to see sometimes delays in language, delays in those social engagement as well. So at around 2 years old, when you're expecting to see some of that more advanced language and more participatory play, sometimes we can notice delays in those social skills. The toddler years are an exciting time of development. We see so much blossoming of different areas. And so that's when we start looking at that problem solving, the play skills, the early communication that can often be impacted. We know that a child across their lifespan has about a 50% chance of having a developmental delay or disability. And I think what's important to know is it's hard to predict what that may be for a lot of these families. And so watching the different areas of development as they come on board is important to start noticing those delays early.
Is it more predictable for this population?
Is it more predictable?
Yeah, in terms of what to expect. Does surveillance help in this? Because we're going to argue the surveillance is vital here. In some ways, I guess, expecting to find something makes you more likely to look for it.
If people are aware of what to expect and what to look for, absolutely. And that's a part of the reason we are interested in kind of sharing more information with the community, with schools, with pediatricians, with families, because the more we're aware of it, the more we are able to look for it. some of the delays that we see are mild, especially to start with. And so a lot of times, if there was not an awareness of the likelihood for delays, sometimes those concerns just get kind of pushed aside. Oh, some kids are just late to walk or late to talk. And so let's just wait and see. What we know about this group is the progress a child makes as an infant, they often aren't showing as much difference in their development. But as they get older, that difference widens. And so a child who has slight motor delays at 6 months old, you may, in a general population, be like, oh, it's just a slight delay. Let's wait and see. For this population, because we know that the trajectory of motor skills actually does not progress as fast, we would expect that delay to get bigger. And so the more we can monitor it early, if we do identify those early concerns, we can go ahead and get services and supports in place and not wait to see if it's going to get better or worse.
Does the degree of developmental deviation correlate directly with the severity of the heart disease? Or it seems that what you're saying is that we need to be especially aware for everyone.
Absolutely. Yeah, it would be so nice and easy if it was that straightforward. If it was like the more severe the heart disease, the more likely there's going to be delays. It's more like that old school Plinko game. I'm not sure if you're familiar with that, where you just kind of put a coin in and you watch it go and it hits the different pegs and it ends up in a hole. And you're like, wait, I put it in the same exact way. I should expect it to come out the same exact way, but it doesn't. There's so many factors in there that push development one way or another. Kristi was telling us about all the different things that affects development through prenatal and beyond. And we can't predict each one of those things. Some children are going to have complications with their surgery and some aren't. Some heart defects are related to genetic conditions, others aren't. And then there's the family factor. So there's way too many factors to predict outcomes. And believe me, the field has tried. There are so many researchers that are trying to figure out, oh, we could just predict it. We could see less kids in our clinic and we could have more time for the ones who really need it. But the truth of the matter is we're really bad at predicting who needs what. And so the approach then is to monitor these children closely, regardless of how severe their condition is.
I'm going to ask a couple of questions that I think are sort of absolutely in the wheelhouse of the average pediatrician, but I think we're wanting to make sure that we want to look at this problem with the same eyes we look at everything else. So how do these delays impact children then as they get older, especially in school and social settings?
Definitely, we see ongoing concerns across the lifespan beyond school. When we think about the development of a child with CHD, not only do those early concerns have domino effects in different areas, especially if we don't address them, but there are new concerns that arise as a child's brain continues to develop. Some of the areas that are most impacted by congenital heart disease are not developed yet, and so we can't even look at it in the early stages. If you think of executive functioning, of attention, of things like ADHD and learning disabilities, learning to read, math, those sorts of things. We can't even assess those things as an infant, but we do know that the same way that CHD affects the brain development early, it continues to affect the brain development when these other skills are expected to come on board. So as a child enters the school age, one of the areas we look closely at is the attention piece. ADHD is much higher in this population, along with learning disabilities. And so for a family to be aware of that going into school and having a good sense of where their child is developmentally at that point can give them a better indication of what to expect for supports that would be helpful in school. And also, again, to take those concerns seriously earlier than we would maybe for a general population. So if reading is slightly difficult for a child early on, let's go ahead and get those supports in place instead of waiting for them to fail and to feel like their academics is their fault and they're just not able to learn. As the child goes through adolescence, executive functioning, the ability to think before you make decisions, and the ability to even manage. Some of our children have ongoing medical needs that they have to continue to manage, like taking medicine every day at the same time. That's hard for everyone, but especially for a child with difficulties with executive functioning. So these things have impacts at their school, but it also impacts their health. It can impact their ability to make and keep friends. And so I think being aware of what can kind of continue on into adolescence is super important. And then we haven't even touched really on that mental health piece, but there are also higher rates of behavioral health and mental health concerns as well. So anxiety and depression, which can come into play at any age, especially with some of the medical procedures and medical anxiety that these kids are dealing with.
I think that one of the things that's quite striking is that many of these issues, while we sort of discuss them as discrete issues, are so multifactorial that neglecting some part of the puzzle just seems like it's just setting kids up to have more problems.
Absolutely. And I think it also can lead to families feeling like they have not done enough or they have not been aware of what's going on and they have not been able to support their kids. So it can really affect the whole family dynamic as well. And I don't want to talk about, children with CHD and their families in a way that is, all these problems, all this negative. There's a huge amount of resiliency in this population. And a lot of kids thrive. And especially if we can get these early supports in place, then they thrive in school and relationships and as they transition to adulthood as well.
In my practice, I don't think of patients as being part of some sort of faceless crowd, but each one's a biography. And I think what you're trying to persuade us of is that this is a population that deserves to be looked at in a particular way to aid each individual person, each individual family.
Absolutely.
And this, I think we'll be making much more of this over the next couple of weeks. What's the advantage of engaging the education system early in helping these kids?
I think it's the same as for any child in an education system. The more that the family and the school partners early and the more that they understand each other, the more likely we're going to have the same goals and go into it as a team. What happens sometimes, I think, when there's either misunderstanding or a school isn't as familiar with the impact of CHD that we've seen just from families who have come through our clinic is a lot of frustration on both sides of the coin, frustration from the families and also frustration from the teachers. Having a child in your class that may have executive functioning problems that makes them a little harder to pay attention or to focus. A lot of times if a school is not aware of the impact of CHD on these ongoing developmental areas, they see a scar and they think the child has been fixed. So their heart is fixed. Why is this still a problem? If we can educate the school system and bring them into the conversation early, then we're more likely to be able to work with a team and create those goals ahead of time so a child doesn't have to fail to get support, but they can go in with supports in place and they can be more successful.
In my experience, schools are most of the time relieved to be able to have a rationale for helping a child.
Absolutely. And it's not something that's used, as an excuse. Oh, we shouldn't expect them to do this because of that. But it does give a little rationale and it gives support for why they may be able to advocate for additional services. So under the school system, if they need additional supports, for example, through an IEP, they have to choose a category where the child is placed. For a child with CHD, sometimes that category can actually be other health impaired. So they may be scoring on a cognitive test in a range where they wouldn't normally receive services. But due to the executive functioning and the attention and the things that are coming up, they may be able to qualify because of other health impaired and then still receive some of those services to be more successful in the classroom.
And it's absolutely part of what a pediatric provider tries to do, watching for developmental deviations. But if I understand you, I think maybe the take-home message from this is that we look with an eye that anticipates that if there are deviations, we need to take those very seriously.
Yes. So we're not going to take the wait and see approach as much with this population because that wait and see can lead to a domino of other effects if we're not getting in there early. So absolutely.
With other situations, we're on the lookout for everyone. In this population, we try to just have more concern, more heightened concern about these things.
Yeah, more awareness, what to look for and when to look for them, and taking them seriously from the beginning.
So it sounds like the conclusion we've come to is the miracle of modern science really enables the survival of a lot of kids who may not have survived in the past. But it absolutely behooves us, if we see every life as a biography, that we try to make the early chapters support success in the later chapters.
I love it. I couldn't have put it better myself.
Anything else you want to say? We'll talk more about this. I mean, this is just sort of laying the foundation. Any other points you wanted to make this week?
No, I think that covers it.
All right. Kristi, you're still around. Anything you think we should have talked about?
No, I'm just grateful to be able to highlight this and to be able, as you so appropriately stated, that survival is improved and we get to think about the whole child instead of thinking of them as a disease process. And this is a great opportunity to continue taking care of children in a multidisciplinary way as our lives and the medical system continues to subspecialize even more. And I think that this is an area where we can continue to take advantage of the really diverse skill set of all the people that we work with to be able to collaboratively care for these patients and their families.
Next week, we'll be talking with a couple of your colleagues about some particular guidelines and monitoring. Thank you so much for your time and expertise. I'm sure there will be a lot of questions. Honestly, going into this, I really was overwhelmed by how much I didn't know about this particular topic. I think that's probably true for a lot of us. So thank you so much, both for being available to talk to us this month, but also for all the hard work you're doing and trying to raise awareness generally. To our listeners, please send your questions to questions@vcurb.com, and we'll bring those up in a couple of weeks. Thanks for listening, and we'll talk to you again next week.
Thanks so much.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Paul Wirkus, who also composed the theme music. See you next time.